So I want to welcome everybody to Internal Medicine Grand Rounds today and thank everyone for joining. Today, we will focus on an update in sort of new issues in nephrology. And we have joining us four of our really distinguished faculty members in nephrology, all of whom have been with us here at Emory for many years. I already warned them, rather than really doing justice to their contributions with long introductions, I'd rather have time for the talks that they're about to give. And so we will start out with Dr. Jose Navarrete, who will talk about COVID and the kidney. He will be followed by Dr. Vandana Niyyar, who will speak about new issues in vascular access for patients on hemodialysis. Following that, Dr. Franch will discuss nutrition in the kidney. And bringing up the rear is Fred Rahbari, who will talk about SGLT-2 inhibitors. And so thanks to the four of you in advance so much for doing this. We will save questions till the end and see what time we have at the end. But please feel free to put questions in the chat box and I'll moderate that at the conclusion, depending on our time. So without further ado, then let me turn it over to you, Jose, and let you get started.
Perfect. Well, thank you for the opportunity. What I would like to do in the next few minutes is share with you what we've learned and what we've done over the last few months in reference to the kidney and this pandemic. I'm going to start with a case of somebody who we saw at Midtown early on the pandemic, 66-year-old African-American male with history of glucose intolerance and hypertension, treated with lisinopril and diet, who was admitted with fever, cough, and mild dyspnea. He was diagnosed with COVID-19. At the time of admission, had a creatinine of 1.2, and he was discharged 4 days later with a stable renal function and improved respiratory symptoms. He returned to the hospital a week later with anasarca, creatinine of 4.7, and 9 grams of proteinuria. His renal ultrasound showed enlarged echogenic kidneys, and eventually had a kidney biopsy that showed collapsing glomerulopathy, a type of renal histological pattern that we tend to see very commonly in patients with HIV infection. This patient was not HIV infected, and the questions that we had at that time was, is this a COVID-related problem? How common is proteinuria in COVID-19? Will the renal function improve on its own? Will the anasarca and proteinuria improve on its own? How do we treat these patients? So that forced us to look at what is the prevalence of proteinuria in patients with COVID. And by now, there are close to 10, 12 series of patients that have been published in the literature that look at the prevalence of proteinuria on admission in patients with COVID. That proteinuria ranged from 25% up to 75%. Our patients at Emory, that number is around 80% for any degree of proteinuria. Obviously, for nephrotic proteinuria, the numbers are lower. Published literature puts that number between 1.5 up to 8%. The Emory numbers for the patients who we collected in the first 3 months of the pandemic puts that number around 7%. So not an uncommon problem. The next question that we wanted to answer is, what does it mean? What is the implication of having proteinuria on admission of a patient with COVID? So we decided to look at this, and we only took patients that have a normal renal function on admission. So these are all Emory hospitals. The first 3 months, we had 272 patients admitted to the hospital with normal creatinine on admission that were tested for proteinuria. And we look at the risk of reaching what we call AKI stage 3, which is the most severe form of AKI when your creatinine is over 4 or you need dialysis. And you can clearly see on this graphic that patients that had no proteinuria were less likely to reach more severe stages of kidney disease. So it's a clear association between the severity of proteinuria on admission and the risk of severe renal disease and AKI in needing dialysis. And I remind you, these are patients that have normal renal function on admission. So a strong predictor of AKI in the hospital. So what do we know about kidney biopsies in COVID patients? There are not that many big series. The largest series published from France, 47 patients, mainly men, with an average age of 63, with several comorbidities, as is common in these patients, with symptoms that are very common too, including fever, cough, shortness of breath, and diarrhea. Pyuria and hematuria were very common in these patients. Up to 50% of them had it. And obviously all these patients, most of them develop AKI, and 64% of them require renal replacement therapy. And the kidney biopsies in these patients show two different patterns. One of acute tubular injury, what we call ATN, up to 42% of the patients. And over a third of the patient had a glomerular injury consistent of collapsing glomerulopathy and focal segmental glomerulosclerosis, which is part of the spectrum of podocyte diseases. Two patients had acute vascular nephropathy, kind of a renal limited TTP, and 17% of the patients had different diagnoses, had nothing to do with COVID. So the important lesson for this biopsy series is that acute tubular injury occurred almost invariably in the setting of severe forms of COVID, whereas collapsing glomerulopathy was only observed in patients of African descent with APOL1 risk variants, very similar to what happens in patients with HIV-associated nephropathy or collapsing glomerulopathy non-HIV associated. At the last follow-up, half of the patients that required dialysis initially were still requiring it, and 9 of the patients had died. These are the histological patterns with a lot of tubular injury and tubular dilatation. Figures B and C shows what we call collapsing glomerulopathy, where the vascular tufts implodes and you have a prominent proliferation of epithelial cells. And figures E and F show the vascular occlusion that is very typical of thrombotic microangiopathy, in this case, renal limited thrombotic microangiopathy. Treatment, unclear. There's not enough cases to say how these patients should be treated. This slide kind of summarized that those findings. All these patients admitted with COVID that are subject to the common situation that a sick patient faces: mechanical ventilation, sepsis, hypercoagulability, myocardial dysfunction, volume depletion. All these things can result in kidney injury. But if it's in the form of acute tubular injury, you're going to have a low grade of proteinuria. But those patients that have APOL1 risk are those the ones that tend to develop nephrotic proteinuria. Now, a patient with COVID can have pre-existing kidney disease or develop other problems that may result in any degree of proteinuria. And another thing that we did and took a lot of our time was to design a strategy to limit the spread of COVID in our dialysis unit. And this work was led by Ronki Apata, and we're so fortunate to have it in our division. So for the first through 2 months of the pandemic, we came out with different strategies from how do we test the patient, how do we put the patients that are COVID in our dialysis unit, how do we make sure that our personnel in the dialysis units do not acquire COVID? Do we need to do, for example, surveillance of patients in the dialysis unit, even though they may be asymptomatic? So this slide kind of delineates the time frame of those interventions in our dialysis unit, and this is the result of that intervention. So far in this is up to January, at the end of January of this year, 18% of our dialysis patients have acquired COVID. Obviously, these steps in the cumulative cases correlate with what's happening in the community. And you may say, well, is this good or this is bad? We are a year into this, and almost 20% of our patients have acquired COVID. There are not that many series like this in the literature. Just as a reference, for example, in London, at the beginning of the pandemic, which is when this data was obtained, they got to 20% of the dialysis patients infected with COVID in 6 weeks. So I think that compared with what has happened all over the world, the containment of COVID in our dialysis unit has been fairly good. And the other thing that we're looking at is, we all know that patients with COVID died and the mortality is increased, and that mortality is related to the acute event. And we define mortality by how many patients don't make it over the first month of the disease. But we're starting to see in our dialysis patients, this is preliminary data, that there may be a delay effect of mortality of COVID that goes beyond the first 30 days. So if you ask me what is the mortality of our dialysis patient with COVID, I will tell you that at 30 days, is around 10%. But if you extend this up to 120, up to 3 months, that mortality may be up to 20%. So what we're trying to figure out is this real as we collect more patients? But this is something that we're going to be looking at to make sure that this thing is not continue, or there are situations here that we can intervene to limit this increased mortality. Another big part of our time was to try to define the epidemiology of the end-stage renal disease patients admitted with COVID to the hospital. This is data that our group just published last week. We look at all the Emory hospitals, again, for the 3 months of the pandemic. All patients tested with PCR for COVID. We have 554 dialysis patients admitted to the hospital. 64 of them were positive, 60 hemo, 4 PDs. Most of them were African Americans. A very common age for all the series that are published, mainly males, 31% obese, 66 diabetics, heart failure, peripheral vascular disease, COPD present in all these patients, as is very common in all dialysis patients. Our mortality was around 17%. And that number compares very well with what's been reported in the world. Just as a reference, during the early months of the pandemic, New York reported a mortality in dialysis patients of around 35%. The numbers from Spain, France, Italy are also in the upper 20s. So this is a very decent number. And the predictors of mortality were age, a high C-reactive protein, an elevated D-dimer, and the presence of peripheral vascular disease. So a lot of what we did at Emory at the beginning was focused on the risk of thromboembolic risk, and this is the cutoff that we set up on patients to initiate anticoagulation. What we learned since then, especially in dialysis patients, is that D-dimers are not unique of patients with COVID. We've also looked at the patients, these are dialysis patients that were COVID negative. And you can see here that even in dialysis patient COVID negative, the D-dimers were elevated. If anything, the D-dimers were a little bit higher on those patients that were COVID negative than the COVID positive. So we're still investigating this, trying to understand what it means, but it certainly has some implications when it comes to make a decision about prophylactic anticoagulation on dialysis patients. I think that it should not be just done on the fact that they have a COVID test that is positive and they have a high D-dimer, as patients that don't have COVID also have a high D-dimer. And lastly, I would like to say thank you to many people that have been involved in the monitoring and caring of these patients. And I would like to make special attention to how Franch has been tireless guiding this long group of people in monitoring this data. Thank you so much.
Thank you.
Let me see how I stop sharing. There you go.
Perfect.
Thank you. And thank you very much for the opportunity to talk about hemodialysis vascular access. And these are my disclosures. So why is vascular access important for our patients? So when we look at the dialysis patient in 2021, what we are actually looking at, this is graph from the USRDS data that can show you that the highest increase is in the age groups 65 to 74 and those that are over 75. Not only that, our dialysis patients have a lot of comorbidities, and this is cause-specific mortality in dialysis patients, hemodialysis patients who died in 2018. And when you look at the prognosis of the dialysis patients, this is a study from New Zealand that compared the prognosis. The line in green is the patients on dialysis. And as you can see, their outcome is worse than those of patients with invasive breast and invasive colon and rectal cancer. So we are looking at an elderly population, a population with a lot of comorbidities that have a very poor prognosis. And it's up to us to focus on patient-centered innovation. And it won't come as a surprise to anyone that what patients want is not necessarily the exact same thing as what we as providers think that they want. And this is data from the Delphi study, where the SONG HD study looked at outcomes and were finally able to come up to 4 outcomes that were aligned between both patients and providers. and I'm going to focus on vascular access. So ideally, the vascular access, the hemodialysis access, is the way that we access the circulation for dialysis. And this lifeline should last for a lifetime. The three common hemodialysis access options available to us are either an arteriovenous fistula, and when we say arteriovenous fistula, we name the artery first and the vein second. So this is a fistula. This is a graft, an arteriovenous graft, and I'm sure all of you are very familiar with the central venous catheters. An arteriovenous fistula is the connection of a native artery to a native vein, and when the vasculature isn't good enough, the patient is referred for an AV graft. Now, if we were to design an ideal access, we would like all these characteristics within that access. Something that should be easy to place, ready for immediate use, and can be accessed repeatedly and consistently to provide us sufficient blood flow for adequate dialysis, should have a low rate of complications and patency for a long period of time. Unfortunately, the ideal access does not exist yet, but when you compare the three hemodialysis vascular access types, a fistula, a graft, and a catheter, once you get past the primary failure rate and the long time it takes for maturation, a fistula is considered the best access for most of our patients, not for all. And if we go down the history, in the 1960s, the first thing that we used for access to the circulation was AV shunts, which were really just a Teflon U-shaped material connecting an artery to a vein. But as you can imagine, this was fraught with complications of infections and stenosis and thrombosis, and were really used in acute dialysis. When we moved on to chronic dialysis, that's when we had the radiocephalic fistulas, the Brecciae semina fistula. But in the last 55 years, since we started using these chronic fistulas for patients, we've really had not much changes in surgical results. They still have a very high failure rate. The time to 2-needle cannulation is over 4 months. And despite all the efforts by everyone, including CMS guidelines, more than 70% of our patients initiate dialysis with a central venous catheter. And things really haven't changed much in all these years until last year, when there has been a paradigm shift with endovascular AV fistula devices that create fistulas percutaneously. So here you can see on your left is the wavelength device, and on your right is the Ellipsys device. Both of them are very similar in that they can provide an AV fistula without the need for surgery, but there are subtle differences. So the wavelength uses magnets and radiofrequency energy, and it's a dual catheter system. So you have to have one device in the artery and the other in the vein, and it is done under fluoroscopic guidance using the brachial, ulnar, or radial vessels. The Ellipsys, on the other hand, is a thermal resistance device. It uses heat and pressure. And the advantage of the Ellipsys is that it's a single catheter system. So you use one catheter, and I'll show you a video on that, but it's completely done under ultrasound guidance. So no radiation, no contrast, no fluoro. And the vessels that are commonly used are the proximal radial artery and the perforating vein. So here you can see an image where the venous catheter is introduced and advanced to the site that's chosen for the AV fistula. And then after an arterial puncture, the arterial catheter is then introduced and advanced to the same location. Once you have both your catheters in place, they are rotated to allow the magnets to align with each other. And then the venous electrode is deployed and a 2-second burst of radiofrequency energy is given. And this, as you can see, almost immediately creates a connection between the artery and the vein and creates a fistulogram. And this is 24 hours post-procedure. And similarly, in this device, which is the other one, which is the Ellipsys device that uses heat and pressure, the median cubital vein is cannulated at the elbow. And here you can see these are the veins, and in the red are the arteries. And once the access is cannulated, you go through the vein into the artery, and the needle is then removed, and a 6 French catheter is then inserted over the wire. Once this catheter is in place, in position in the proximal radial artery, then the wire can be removed and the device can be introduced. So this device, as you can see, it is introduced through the sheath, passes through, and then literally goes through the vein into the artery, and it captures both the arterial and the venous walls. And once that's done, this device is then activated, and this allows for the pressure and the heat to create an anastomosis between the artery and the vein without surgery, and then allows the creation of a fistula once the device is removed. So when these studies were looked at, and these studies just received, these devices both received FDA approval this past year, you can see that the characteristics of the patients in each of these devices were very similar to the kind of patients that we see in our daily practices. They were also had a high incidence of hypertension, and 2/3 of them in both studies had diabetes, and over 40% of them had central venous catheter use that were already on hemodialysis. And in the right hand, there is excellent technical success in the studies that were done initially investigationally, as well as more have been now released in the last year. The cumulative patency exceeds that of surgical AV fistulas. As you can see, 83.5% with the wavelength and 87% with the ellipsis. And so the advantage of these devices for our patients, not only do they not have to have the surgery, but the main thing is it provides them 2 additional options in the forearm before we have to move up to the upper arm. So if the patient is a candidate for a distal surgical fistula, that's the first choice. These devices in the mid forearm are the second and the third choices. And then you move up to the upper arm for the brachiocephalic or the brachiobasilic AV fistulas before you have to move on to grafts. There are certain limitations because you do require a detailed preoperative vascular evaluation. You need to have the 2 vessels in close proximity to each other, less than 2 millimeters. And it does require a learning curve. So the proceduralist has to be familiar with both ultrasound as well as fluoroscopy. And secondary procedures are required. When this device was investigational, these secondary procedures were actually done at follow-up, but now they are being done at the time of the index procedure itself. The one thing we really don't have any data for is long-term data, and there are no comparisons, direct head-to-head comparisons with surgical AV fistulas. However, knowing the patency and the technical complications and the failure rate, they do seem to be very appropriate alternatives to surgical AV fistulas. The one concern as we start seeing more of these within our dialysis units is the fact that these, because they are in the forearm going up to the upper arm, there is split dual flows. And so if there is going to be a need for ultrasound to guide the cannulation, as the flow may be split between the 2 vessels. So the take-home points for the endovascular AV fistulas is that they have high technical success rates and low complication rates. And their cumulative patency is at least as good as surgical fistulas, though it must be individualized to each patient's particular vascular anatomy. So can we say that this is a lifeline, or if we have, this is now finally an ideal access? Not yet, but I do think our goal in dialysis is to provide the right access for the right patient at the right time for the right reasons. And it's up to us to find the balance. And as we look towards how innovation has changed, this is the first dialysis membrane since the 1850s. Thomas Graham used an ox bladder semi-permeable membrane that led to the first practical human dialysis machine. You may all know Dr. Koff as the father of artificial organs. He was also the mentor for Dr. Jarvik. And the first dialysis machine that he made was in World War II in a small village where he used a laundry tub, a wooden drum, and cellophane paper. And we've come a long way to the current dialysis machines that we use right now, to moving on to these wearable artificial kidneys that are now in phase 3 human trials. And hopefully within our lifetime, we'll get to see the implantable bioartificial kidney where our patients don't even need to be on dialysis. And what's very encouraging is that the Kidney X Innovation Accelerator is a partnership between the American Society of Nephrology and the Department of HHS. And in their competition, this is from someone who's very biased in dialysis vascular access, but 30% of the finalists and 50% of the honorable mentions were all in the field of vascular access. So I really do believe that the future is now, and it's up to us to make the most of it. Thank you very much, and I'll take any questions at the end.
Thank you, Vandana. Perfect. You're on mute.
Okay. All right. Do this again. And, all right. Can everybody see? All right. So what's going on in clinical nutrition? A new update of the main clinical practice guidelines that went out in 2020. And what was really interesting to me in this was the impact of diet on renal death. That's death or going on to dialysis in chronic kidney disease stages 3 through 5. I have no conflict of interest regarding this presentation. In 1848, Richard Bright used urine protein to diagnose kidney disease, and within 10 years, Bright's disease, patients with Bright's disease survival improved with high vegetable, low protein diets. These traditional low protein diets, which were codified to be about 0.6 gram of protein per kilogram per day in the 1940s, were used in CKD stage 3 through 5 well into the 1990s, although the fruit and vegetable content was lowered to reduce potassium intake. In the 1990s, randomized clinical trials of low versus moderate protein, 0.6 versus 0.8 gram per kilo per day, had inconsistent results. So in 2000, the NKF Kedoki Nutrition Guideline recommended 0.7 gram per protein per kilo per day, essentially ending the use of low protein diets in chronic kidney disease in the US. Additionally, pharmacology mimics the benefits of traditional renal diets on progression of renal disease. So for example, low protein reduces hyperfiltration, but so does RAAS blockade. And as Fred is going to talk about, SGLT inhibitors. Low protein reduces net acid load, but you can always give oral base. However, there is no substitute for low protein diets to reduce nitrogen-based uremic toxins that accumulate in dialysis. Low sodium was a part of these early diets because salt meat was the major sodium source in the British diet, and low sodium diets have continued. They reduce hyperfiltration and cardiac risk, but once again, diuretics, RAAS blockade can replace them. And high vegetables also reduce cardiac risk, but oral base and antihypertensives and statins all have similar roles. So when you think about in the 2000s, we were very interested in the effect of decreased nutrient intake on wasting and how that led to complications like infection, cardiovascular disease, and frailty. And dialysis was noted to impair the ability of patients to use low protein diets. But quickly it was realized that inflammation, comorbid conditions such as cardiovascular disease, diabetes, also had similar roles, as did metabolic acidosis. The question then arose, since uremic toxins also seem to cause protein energy wasting, is the benefit of reducing dietary protein on reducing uremic toxins, does that outweigh the direct effect of decreased protein intake on protein energy wasting? And this is where we are going into the 2020 guidelines. These guidelines were a joint project of the National Kidney Foundation and the American Academy of Nutrition and Dietetics. So they were a distinctly American project. However, the study group contained physicians and nutritionists from 4 continents. And the guideline was developed according to the standards for developing trustworthy clinical practice guidelines, with recommendations levels of 1, strong, we recommend, and 2, we suggest. Evidence grades went from A, the highest confidence, to D, the lowest confidence. So what do these guidelines say about modern use of traditional low protein, low sodium, high vegetable renal diets? The first and most controversial finding was that low protein diets reduce death in patients with CKD stage 3 through 5 who are metabolically stable under close supervision. And they also improve quality of life. And these are 0.55 to 0.6 gram per kilo dietary protein, or even lower protein diets supplemented with keto acid, amino acid analogs to meet the protein intake. So what is meant by metabolically stable? Well, here's a slide produced by the working group so that basically it's no wasting, no inflammation. So patients with poorly controlled diabetes, consumptive diseases like cancer, significant short-term weight loss, immunosuppressive medicines like transplant recipients, patients with active infectious disease, all were not recommended to receive low protein diets. Now, when you select patients in this way and look at 13 randomized controlled trials, the risk of end-stage kidney disease or death fell with an odds ratio of 0.62 in the low protein diet group versus higher protein diets, with improved quality of life scores, improved serum lipid profiles, and with the protocols in place, the dietary protein could be effectively reduced and used as an index of adherence to the diet. And there was no effect on blood pressure, serum albumin level, or anthropomorphics. In other words, there was no evidence of protein wasting with the low protein diets. However, there are significant barriers to implementation of such diets in the US. First, you have the patient selection is obviously critical. These RCTs used dietitians and RNs specially trained in low protein diets. There were 6 to 12 dietitian visits a year, depending on the protocol, and Medicare only pays for 3 visits a year. There were 2 to 6 24-hour urine collections done to measure protein intake a year in these trials. And our patients who ride buses or public transportation have a hard time bringing 24-hour urines in. Most trials were performed in culturally homogeneous locations, making diet education significantly easier if people are all eating similar diets. And the keto acid, amino acid analogs are not widely available in the US. And the composition of the one brand available in the US differs from that in the recent RCTs. Now, the question is, are any diabetics metabolically stable? What happens when you do the same studies in patients with diabetes? Well, they notice with the strength of opinion this time, as opposed to 1A on the previous recommendation, that patients with diabetes maintain a stable nutritional status and optimize glycemic control at a 0.6 to 0.8. So either under low or moderate protein restriction, they maintain a stable nutritional status. But they could not say anything about renal death. The 11 RCTs were heterogeneous in their effect of 0.8 versus 0.6 gram per day protein. And a meta-analysis of all these studies showed that the benefit, while significant, the change in slope of eGFR was less than 10%. Few studies use the gold standard of renal death as an endpoint. The trend was toward improved renal death with the low protein diets, but it did not reach statistical significance. Thus, the data does not support at this point a recommendation of low protein diets for diabetics. Now, what about dietary sodium in the era of RAAS blockade and powerful diuretics? It's not surprising with a recommendation of 1B that patients with CKD 3 through 5 should have less than 100 millimoles or less than 2.3 grams a day of sodium to reduce blood pressure and improve volume control. And their 10 RCTs were extremely consistent on this effect. In adults with CKD 3 through 5, the data was of high quality, but they felt that not all patients with proteinuria, you may need to select certain patients with proteinuria to have this. That's why they gave it a 2A recommendation. That it also synergistically reduces proteinuria. And there were 3 RCTs on proteinuria, and they were entirely consistent. And the drop in, it was an additional 25% drop in proteinuria compared to the addition of the ACE blockade plus the low sodium diet by themselves in a crossover design. Now, blood pressure and proteinuria are the 2 best single predictors of renal death, and doing a high sodium randomized trial would not be considered ethical at this point. Now, what about vegetables? They recommend on a level of a 2C, so this is a lower evidence of evidence, that dietary fruit and vegetables, by reducing net acid production, by reducing acidosis, that it causes a decline in the residual renal function. And then they also recommend increasing bicarbonate using sodium bicarbonate or a citric acid sodium citrate supplementation in order to reduce the decline in renal function. In an opinion, they set this rate at 24 to 26 millimoles per liter. The idea is that you reduce the amount of sodium, that you use fruit and vegetables to reduce the amount of sodium you're giving patients with sodium bicarbonate or citric acid. Now, they gave relatively low confidence grades on these, but my opinion on this is considerably stronger based on studies that have come out since the closing of the evidence guideline, the evidence for these guidelines. For example, if you look at the UBI trial, which is a cluster randomized trial in CKD stages 3 to 4, where they supplemented patients who started with serum bicarbonates of around 22 and increased them to 24 to 26 with supplemental bicarbonate. And this is about 360 patients in each group. You see that the sodium bicarbonate group had about half the mortality and about half the dialysis inception as the standard group. And you can see, oops, I'm sorry. You can see the separation between the 2 groups was good throughout the study on the serum bicarbonate. Thus, it does look like this 24 to 26 range that they're suggesting as opinion may be good, not only for reducing net acid production, but also for renal death. Now, vegetables and fruits have the same benefits in the general public and in CKD, that a Mediterranean diet does appear to improve lipid profiles in CKD 1 through 5. And in adults with CKD 1 through 4, it does look like increasing giving fruits and vegetables decreases body weight, blood pressure, and net acid production. As you get into CKD4, the effect of the diet on blood pressure is somewhat lower, however. And finally, when you give more fruit and vegetables, you're not going to be able to prescribe every patient a 2-gram potassium diet. So in their opinion, they believe it's reasonable to adjust dietary potassium with an intake to maintain serum potassium within the normal range. So to summarize my conclusions about the recent guidelines, unselected patients, including diabetics outside of specialized clinics, should be prescribed 0.8 gram per kilo per day protein diets, and higher diets may be needed in acute illness, patients undergoing chemotherapy, for example. Selected patients in specialty renal nutrition clinics can be treated with 0.55 to 0.6 gram per kilo per day under careful supervision. And we are working on setting up such clinics at both Emory and the VA. Dietary sodium should be restricted to under 0.23 grams per day. And you should consider continuing heart-healthy diets, including fruits and vegetables, as long as possible in CKD 3 through 5. Vegetables and fruit can minimize the amount of sodium-based supplements that need to be given to raise the bicarbonate to 24 to 26. And restrictions on vegetables and fruit may be required to lower serum potassium. Thank you very much.
Can you hear me?
We can.
Okay, good. So I'm going to try to talk about the SGLT-2 inhibitors in chronic kidney disease over the next 20 minutes. As a disclosure, I'm the PI for the EMPA kidney trial that's ongoing right now. These are my full disclosures. The objectives of the talk are to understand the contribution of proximal tubule to glycemic control and the rationale behind using sodium glucose linked transporter 2 inhibitors in CKD, to review the results of the main randomized trials of these agents in CKD, and there are 2 of them, CREDENCE and DAPA CKD studies that I'm going to mention, and to emphasize on the importance of implementing the use of these agents in chronic kidney disease. Why to talk about these agents? As a reminder, these are the only renoprotective treatment that have been developed for all-cause CKD over the last 20 years, since the captopril, IDNT, and Renal trials. Obviously, we're not counting the glomerulonephritis, polycystic kidney disease, and some other rare diseases. The cardiovascular benefits are as exciting as renal benefits, and there's interesting physiology. And if that's not enough for the audience, it's a hot topic. If you PubMed it, you're going to have 5,000 entries and 9 New England Journal papers since 2015, with a total recruitment number of almost 60,000 patients with billions of dollars in R&D. As a reminder of normal physiology of how the kidneys handle glucose, you basically have the filter load of glucose, and then you have excretion, and then you have reabsorption. So there are 3 components there. Typically, if you're not diabetic, the filter load of glucose that depends on your GFR basically is almost entirely reabsorbed, and you don't have any excretion. At some point, with a renal threshold of around 180 milligrams per deciliter of your serum glucose level, you start actually splitting glucose in the urine. And also the reabsorption starts a little later than that point, and you have reabsorption and an equilibrium. And the reabsorption threshold is basically 375 milligrams per minute. Now, when you become diabetic, 2 things happen at the same time. Your threshold to excrete glucose shifts toward the right, and this is directly dependent on your glycemic control. So it depends on hemoglobin A1C levels that you have. And the reabsorption of the glucose also shifts upward. So this is basically normal physiology, and then what happens, diabetic kidney disease. So where's the action? Again, kidneys regulate mostly through the proximal tubule using the SGLT1 and SGLT1 and 2 receptor transporters. The type 2 is in the S1 segment of the proximal tubule. The type 1 is a little bit down in the S2 and S3 segments of the proximal tubule. And also the type 1 is in the intestines too. The type 2 receptor is high capacity and pretty much takes care of 90% of the work. The other one is kind of the lazy brother and only takes care of 10% of it. And that's why, and then there's also the contribution of the kidneys through gluconeogenesis, which is not the topic of this talk, but that's definitely helping with your sugar control. At the cellular level, basically you have these receptors that are here on the apical side of the membrane, and basically the salt and glucose are trafficked into the cell, and through the glucose transporters and the sodium potassium ATPase pumps are basically brought back to the serum level. That's how it works, and we've known this for many years. There was actually an inhibitor of both these transporters, fluorescein, which basically was coming from the apple tree bark and caused natriuresis and glycosuria in rodent models of diabetes. The problem was that that was not a good intervention in humans because of very poor bioavailability, and also the risk of jeopardizing cell energy function by metabolism of fluorescein to fluoretine. Now, pharmaceutical companies jumped on the occasion and came up with new SGLT-2 inhibitors that selectively target the high capacity SGLT-2 transporter. And now we have many trials based on those. Now, again, if this is your glycosuria curve around when you become diabetic, it's shifted toward the right. When you put them on SGLT-2 inhibitors, you basically drop that threshold down to almost 40-45 milligrams per deciliter. So basically, that tells you there's no non-respondent. Everybody's going to respond to these medication. That's number one. And then what we also know that this drop does not cause hypoglycemia. And the reason for it is that the liver almost immediately compensates for the amount of glucose that is excreted in the urine, unless you have a disease state. But otherwise, usually in most people, that's what you're getting. Now, how's that nephroprotection part comes into the picture is really through the tubular glomerular feedback loop and the hyperfiltration that happens in diabetic kidney disease. So in normal physiology, the macula densa senses how much salt is delivered and basically gives a normal feedback to the glomeruli to basically affect the arterial, the efferent arterial tone, and also the SGLT-2 transporters are part of that physiology. What happens in early stages of diabetic kidney disease, and it persists, for a long time in that disease, is that basically you have hyperfiltration, decreased salt delivery to macula densa, which gives actually an impaired feedback loop to cause vasodilatation of the efferent arteriole. And now you have that hyperfiltration in early stage of diabetic nephropathy. So when you're putting patients on SGLT-2 inhibitors, you're dumping sodium here and glucose. The amount of salt that's detected here is less, so it gives actually a different feedback on the afferent arteriole, causing vasoconstriction, normalizing the GFR. And the difference between the two of these is about 30 points drop, 20 to 30 points drop in your GFR. And that's what's basically restoring that to glomerular feedback loop. Now, there are more, and we've known that based on the fact that even non-diabetics get benefit of that. This is what we already went in at A level. And the B is really that sodium proton exchanger type 3, which contributes to diuretic properties of SGLT-2 inhibitors. But now we know also these agents actually reduce fibrosis, and with a number of intermediate factors such as NF-kappa B, IL-6, MCP1 or mTORC1, and also they drive autophagy and kidney protection by metabolic alterations and activations of sirtuin-1, AMPK, or HIF2 alpha. So this is kind of the physiology part. And then on the cardiovascular, there's also a more complex loop. We know that these drugs basically, independent of your blood pressure target, they reduce aortic stiffness and wall stress. The ketosis that's caused by these drugs is actually beneficial for cardiovascular purposes. Glucagon levels are higher, preload decreases, extracellular fluid volume decreases, and your uric acid excretion and salt and water excretion are increased. There's a feedback on angiotensin and RAAS system, but overall the blood pressure is lower, you lose weight, and your systemic vascular resistance is lower. So we think that because of all these players, that's how we get cardiovascular protection. There's also on the endocrine part, you know what, there's a downregulation of glucose transport system in the muscle causing insulin resistance. That's called the concept of glucotoxicity. And the pancreatic beta cell dysfunction is also there. And these drugs actually improve the downregulation at the muscle level by 35% and improve the beta cell function by 98%. Now, coming to the molecules that have been tried and are on the market, the four first ones are FDA approved: dapagliflozin, Cana, EMPA, and ertugliflozin. So all of these are on the market approved. All of them approved for diabetes mellitus. 3 of them for cardiovascular disease or heart failure. And the only one approved for diabetic kidney disease is canagliflozin. Dapagliflozin has applied to the FDA in December for approval for all-cause CKD, and that's pending, and I'm hopeful that within the next month or 2, it will get approved. And the other agents are basically all investigational right now. You can see that the urinary excretion and elimination of these drugs are actually different. Some of them, most of them are primarily urinary, but Cana is actually 52% fecal. These are once-a-day drugs. Half-life is about 12 hours. And there's, again, the alphabet soup of clinical trials. I highlighted the 2 that are kidney-related, this Credence and the DAPA-CKD. But there's also all the cardiovascular trials, the CANVAS, the EMPA-REG outcomes, EMPA-REDUCED, and declared TIMI-58, the DAPA-HF, and VERTIS-CV. And the first one was a diabetic, pure diabetic trial versus glympiride. So these are all the other ones were placebo-controlled. The first one was basically a diabetic trial. Focusing on the 2 renal trials, Credence and DAPA-CKD were quite different. Credence only took type 2 diabetics. DAPA had both diabetics and non-diabetics with CKD. The age was higher in Credence, 30 and above. In DAPA, it was 18 and above. eGFR by design was lower in DAPA, 25 to 75 versus 30 to 90. The amount of albuminuria was almost identical, 300 versus 200 here, and the maximum was 5,000 milligram per gram. Here, there was an eligibility based on hemoglobin A1C, 6.5 to 12.5. Here, there wasn't. Everybody should have been on ACE inhibitor or ARB unless contraindicated or not tolerated. The N numbers were 4,400 and 4,300, randomization 1-to-1. And primary endpoint was a little bit different. The first one had a composite endpoint of doubling serocreatinine, end-stage renal disease, and death from renal cardiovascular causes. Here we had a time to first occurrence of any of those events. And the 50% sustained decline in GFR was included there. And both of the trials were stopped early at 2.5 years instead of 4 years because the DSMBs, based on interim analysis, found that the protection was very clear and we didn't need to go for any extra time. As far as who got into these trials, you can see that the average age was around 61 and 62 in both trials. These are, again, particularly Credence was primarily Caucasian study, 67.5%. The DAPA was 52%. African-American population was only 5% in both. And you can see that the cardiovascular disease was very prominent at 50% in credence, a little bit less, 38% in DAPA. And the estimated GFR, again, by design, was a little bit higher in credence, around 56 versus 43 in DAPA. What did we see? So in credence, and I'll go over very quickly over all the outcomes. So this is primary composite outcome. This is renal specific composite outcomes. This is cardiovascular causes of death, end-stage renal disease, renal death, meaning including transplant and dialysis initiation. And this is death from all causes. So you can see that there's across the board a 30% protective effect in the glyphosine arms of the study. And here on the total death, it was about 17%. So very, very clear, clearly positive results. When you subgroup analyze the data based on the admission estimated GFR or level of albuminuria, it looks like actually people were more advanced with lower GFR and with higher albuminuria got actually more protection. The bars are not crossing the line. And this is kind of an important message right now that you should not give up if you feel that your patient is more advanced as far as the kidney disease. In DAPA, basically even more pronounced differences between the glyphosine versus placebo. You can see that 39% and 44% in the primary outcomes and renal specific outcomes. Mortality was 31% down compared to 17 that you saw in the credence group, in the credence study. Note that the beneficial effect is very early, particularly in cardiovascular outcome. That tells you that it's not about glycemic control. Even at 2 months, the curves split and the split gets bigger. And the beneficial effects are observed in all pre-specified subgroups, whether it's age, sex, race, GFR, BP, or albuminuria level. So I skip over those, but you basically see the same protection based on those. And whether in DAPA CKD, you had both diabetics and non-diabetics. Therefore, you can actually look at them differentially. In non-diabetics, the level of protection was even higher than in diabetics. You can see that around 50% versus 36 or 43%. So very clear beneficial effect, even in non-diabetics. Now, the nephrology point for my renal colleagues is this curve of change in GFR. We know that every single renal protective measure that intervention that we've come up over the last 40 years has this what we call hemodynamic effect. Whether you take ACE inhibitors, ARBs, the low protein diet, we talked about it, tolvaptan in polycystic kidney disease, all these have this hemodynamic effect that basically your GFR drops by 5 points within the first month of the intervention. Then the curve actually flattens out compared to placebo. At 1 year, you've already crossed, and at 3 years, you definitely have a clear-cut benefit. And obviously, nothing comes for free, and there are side effects to these drugs. Osmotic diuresis is the number one. In average, people pee about 400 cc's more per day, which is great for heart failure patients if you think about those. But if you're already volume depleted, you have to tell them to drink more water. Acute mild drop in GFR, we talked about it. If it's more than 50%, you have to investigate for other causes of AKI. Increased risk of UTI, myocardial infections are probably one of the most common side effects, and they can be mitigated, particularly for UTIs, by using perennial hygiene. Flu-like syndromes, nasal congestion, reduction in insulin requirement by 30% are also seen. Euglycemic ketoacidosis can be present rarely in probably 2 out of 1,000 patients. Not very common, but definitely a major issue. And they're preventable by holding it if people are having acute illness, particularly pre-op. Definitely not when people are diabetic, pregnant. You should avoid that. And increased risk of necrotizing fasciitis was reported with canagliflozin, and constipation is also common. Now, special note, hyperkalemia was actually less frequent in the SGLT-2 inhibitor arm. There was no risk of hypoglycemia associated with this drug. If it happened, something else caused it. AKI was actually less in the glyphosine group, somewhere between 16 to 25%, and the blood pressure was mildly lower, about 5 points systolic, 2 points diastolic. So these are kind of the all the side effects that I wanted to mention. Do not forget that these drugs in the cardiovascular trial that I mentioned, all of them showed actually a protection. And interestingly, patients who had overt heart disease had more protection. So that's not to be ignored. Again, these drugs are cardiovascular drugs and they have renal benefits. And how do they compare to ARBs? I remind you that ARBs did not show any mortality, specific mortality benefits versus these SGLT-2 inhibitors that actually have a 24% drop in mortality. So on the mortality side, SGLT-2 inhibitors prevail. On the composite kidney outcome and death-adjusted effects on the ESRD, they're fairly similar, even though SGLT-2 inhibitors look a little bit better on the composite kidney outcome. And heart failure hospitalization were a little bit less in the SGLT-2 inhibitor. The take-home message is that these are effective even at least as good as ARBs, maybe better on some endpoints. Here, the promises and caveats, again, if we think that if we could implement SGLT-2 inhibitors rapidly over the next few years, we could actually reverse the rapid rise of ESRD incidence that we've seen over the last 4 decades, by 2030. So it's really a matter of urgency. And the protection may be different at different stages of renal disease. I showed you that, and we need more long-term data on early use of these drugs. And relatively low proportion of African Americans in these trials warrants basically more investigation in that particular group that is basically a high-risk group for both mortality and renal disease. Remember that they did not include non-albuminuric diseases in any of these trials. There was no ADPKD patients, no glomerulonephritis, nobody on immunosuppressants over the last 3 or 6 months prior to enrollment. And very advanced CKD was excluded below 25. We're doing the MPA kidney right now, and we're down to 20 of GFR at the time of enrollment. By early 2023, we will have the results and be part of that. I think the conclusions is just what I mentioned. The SGLT-2 inhibitors provide renal cardioprotective benefits by restoring to glomerular feedback, reversing hyperfiltration, reducing extracellular fluid volume, aortic stiffness, reducing blood pressure, losing weight, all the above. The benefits are seen in both diabetics and non-diabetics. Protective roles are class effects, not agent specific. The magnitude of renal protection is similar to RAAS blockades, at least. And all providers should think about starting these agents, whether you're a primary care doctor, internist, endocrinologist, nephrologist, cardiologist, ophthalmologist, neurologist. If you have a patient and with these specific characteristics, you have to think about it. Don't wait for somebody else to call the shot, and start them. Start the one that you can actually get approved by the insurance. Further future directions is actually, again, we ignore that SGLT1 that actually also has intestinal aspect to it. And there are actually studies now, not studies, but they're developing combined SGLT2 and SGLT1 inhibitors. And that's kind of something that's going to come over the next decade as far as development. Thank you very much. And I know that I went a little bit over time. I'll be open to any questions.
Thanks to all 4 of you. Yeah, we are over time, and this is where I miss being in person so that we can have people come to the front and ask questions. So for those of you who want to drop off, please feel free to. We can do a couple minutes of questions, I think, but have to limit it given the number of questions that there are. Quickly, Vandana, a couple for you. The one question is who actually placed, I know the answer to this, but I'm anxious for you to tell everybody who places the devices that you described, and then is the time to maturation of those fistula any different than surgical ones?
Okay, so the first question is who places them? So again, I'm biased, and I really think it should be the interventional nephrologist who does it. I'm a trained interventional nephrologist and not yet doing these procedures here yet. But if you look at the studies, the Ellipsys study, out of the 9 people who did the study, 8 of them were interventional nephrologists. So these are all nephrologists who are trained in the procedures. The wavelength, the primary author, Charmaine Locke, is also a nephrologist. The right answer is basically anyone who has expertise and who cares about the dialysis patients should do it, whether it's an interventional radiologist, interventional nephrologist, vascular surgeon. We have had, right now, the first ones being done at Emory will be at St. Joe's, and it will be by interventional radiology. They haven't started yet, but the plan is in place for them to start. They already have the device. And we are working with our vascular surgeons as well. So again, it is always a multidisciplinary approach to these accesses, and anyone who has the expertise and who cares for dialysis patients should be able to put these in. It's relatively a straightforward procedure that needs to be done and needs just some basic ultrasound skills and fluoroscopy skills. As far as the second question was time to maturation. So the time to maturation is shorter with these. If you look at it in the big picture and you compare the data, it's literally around 4 weeks in most of the studies. And the reason that's hypothesized is that during surgery, there's a lot of trauma and manipulation. So when you're actually bringing the vein over, especially if you're doing a transposition or a translocation, the vein undergoes a lot of manipulation, and that may lead to either juxtaanastomotic stenosis or neointimal hyperplasia that may cause stenosis or thrombosis. So, so far what we are seeing is that the time to maturation is shorter with the endovascular AV fistulae.
Great, thank you. Fred, I think there's a couple questions that essentially are asking about the use of SGLT-2 inhibitors in people with declining renal function.
Yes, so again, there are 2 issues there. One is the evidence of the data, what we have available, and definitely we don't have anything available below 25 as of right now. The EMPA kidney trial is going to go down to 20, but I'm probably out of those, during the trial time. Some of them are going to go and decline, furthermore. So we'll have a little bit more data on that. The issue is several things. One is payment, and obviously, the insurance companies basically go by the clinical trial criteria, and they would approve them for coverage if you really stick to those indications that basically the FDA approved it and what we've published. So that there's one issue with that. So you cannot go too low on GFR until we have more data. That's one. There's also a disconnect, and there was a question that I saw, is there a disconnect between the GFR and other measures that we should think about? And there's definitely data right now showing that there might be a disconnect between the total eGFR that we're measuring based on serum creatinine and a single nephron GFR that you would do in a lab. And there is a little bit of disconnect there. But it seems that at least, up down to 25 of GFR, the drug is actually getting to its site of action and it's actually working on the promised, results. And I think those are the things that I wanted to mention. But again, right now, as of right now, you don't have a way. Even right now, if you wanted to use DAPA for advanced CKD, because the FDA hasn't approved it yet, you have to basically go and advocate it for non-diabetic patients. For diabetics, you can do the CANA, no problem. That's been out. For non-diabetics, you have to basically go and say, pull up the New England Journal paper and say, this is the evidence. And they may come back and say, we're not doing it until we get an approval from the FDA for that label, which I don't think it's going to be too long to come. I'm hoping that within the next 2 months, we'll get the FDA approval on DAPA for CKD, all comers.
Great. All right, well, I think given the time, we probably better close up shop. But thank you guys so much for presenting. This was, obviously there was a ton of interest and an awesome presentation. And so look forward to seeing the rest of you guys next week.
Thank you.
Thank you for having us.
Thank you.